Thank you very much.
Thank you very much, Professor. It's Grigoris, of course. I would like to thank Dr. Sparias, Mr. Patakos, and the organizing committee for the invitation to participate in this very interesting session. I will talk about TAVI in cardiogenic shock. Aortic stenosis is not uncommon in patients presenting with acute heart failure, as we see from this large European registry. What is more important, though, is that aortic stenosis is a factor that predisposes for adverse clinical outcomes, as you can see on the right hand of the screen. From our data in ATTIKON University Hospital, from the data that the cardiogenic shock team that we have developed has accumulated, we see that severe aortic stenosis is the cause of cardiogenic shock in around 7% of the cases. It is a small number, but still important, since we can do something for this patient and improve their outcomes. I will take a step back and go to the pathophysiology of cardiogenic shock, just to remind you that cardiogenic shock is not just a dysfunction of the left ventricle. It involves mechanism of ischemia, vasoconstriction, congestion, and inflammation. And through this mechanism, a vicious cycle is created, a spiral, that at the end, if there is no intervention, it will lead to the death of the patient. And as you can see here, we try to intervene in this spiral, for example, with revascularization in the case of acute myocardial infarction-related cardiogenic shock. It is similar with aortic stenosis. A similar thing happens. Aortic stenosis causes subendocardial ischemia. It decreases the preload, it increases the afterload, and then it leads to acute decompensated and at the end death. So it is important to intervene in order to break this cycle and improve the outcomes of the patient. As cardiac surgery is extremely high risk in these patients, historically, balloon valvuloplasty has been proposed for this patient. But as you can see in this table, which accumulates all the registries that have been published on the above in cardiogenic shock, 30-day mortality remains very high. As you can see, and I will look at the bottom of the table where the more recent trials are, mortality is 40, 50% or even more. So BAV is, although it may offer something, is not the best treatment for this patient. Having this in mind, the last 10 years, TAVI has been proposed as an alternative, and you can see in this table the registries that have been published up to now. I will highlight three things. One is the small number of this registry, with the exception of the one from STS that I will talk about it later. The other is that, yes, the mortality, the 30-day mortality is much reduced if we compare it with the mortality from BAV, but still it is quite high. Nevertheless, most of these publications come from an early era of TAVI. So recently we have this important publication in European Heart Journal. It was published a few months ago in 2023, and it comes from the US, presented data from the STS-ACC registry. These data are quite contemporary, as the study runs from 2015 to 2022. As you can see, this registry is a huge registry with hundreds of thousands of patients. 1.6% of them, it's a bit difficult to solve, so I cannot do it. 1.6% of them had cardiogenic shock. Cardiogenic shock was defined in this study as coding of cardiogenic shock, pre-procedural use of inotropes or mechanical circulatory support, or cardiac arrest within 24 hours prior to TAVI. I will also highlight some baseline characteristics, which is important in order to understand this study, and maybe it will be helpful for the discussion later. The mean age was 75, so these patients were quite young. The ejection fraction was around 40, so it wasn't that low, and less than 10% of them had a prior BAV. What the researchers did is that they did a propensity score analysis. So they had almost 5,000 of patients with cardiogenic shock and compared them with similar patients that did not have shock. And you see the one-year results. Mortality in patients with cardiogenic shock is obviously worse. But what I find more interesting, and actually it's more important in this study, is the 30-day landmark analysis that you can see on the right hand of the screen. You can see that in 30 days, mortality in patients who underwent TAVI and had cardiogenic shock was 13%. But after the 30 days, for the patients that survived, mortality was not different between the two groups. This 13% is much lower than the percentages that we saw in the previous studies. Nevertheless, we have to consider that this is a retrospective study, and obviously there is a selection bias, as these patients were selected, they were deemed eligible to have TAVI. Another important conclusion of this study was the predictors of mortality, and I will only mention renal dysfunction, end-stage renal dysfunction dialysis, which was the most important predictor of mortality for these patients, both in 30 days and in 1 year. So based on this unmet need, the unmet need on treat patients with severe aortic stenosis and cardiogenic shock, and the data that I just presented, the international scientific communities proposed TAVI as a solution for them. And here you see a consensus document from the European Heart Failure Association, EAPCI, and Acute Cardiovascular Care Society. And as you can see, if there is cardiogenic shock in a patient with severe aortic stenosis, the patient can undergo emergent TAVI or balloon valvuloplasty if TAVI is not available, or as a bridge to TAVI. Another similar consensus document that actually involves the working group from cardiovascular surgery compares the theoretical benefit of BAV and TAVI. And we all know them. Obviously, with BAV, you don't treat the stenosis. There is a risk that you have aortic regurgitation, but BAV is maybe more available, it's easier, and definitely it's cheaper. Another important conclusion from the small studies that had applied BAV in patients with aortic stenosis is what we know about cardiogenic shock. And what we know about cardiogenic shock is that it's a clinical condition that is time-dependent. The later you do the intervention that is needed for the patient, the worse the outcome will be. And we can see it here that in the right hand, in the Kaplan-Meier curves on the right-hand side of the screen, patients who underwent BAV in less than 42 hours from presentation did better than patients who had balloon valvuloplasty at a later time. Another study that came from Germany that I found interesting was the one that compared emergency TAVI with emergency balloon valvuloplasty followed by an elective TAVI. And what I find interesting in this study is that the 30 days mortality on the patients that had the hybrid, let's call it this way, procedure, first emergency BAV and then elective TAVI, was quite high. As you can see, it was 22%, which is higher than what I expected, higher than what I think a lot of us would expect, and actually sets questions about this strategy and whether it is the best strategy or whether we should go straight with an emergency TAVI. But what we have to consider, and what is more important when we talk about this procedure, is the balance between benefit and futility. And from the consensus document that I showed earlier, this is the factor that we have to consider for futility or benefit. First of all, age. If there are other comorbidities in the patient who presents with severe aortic stenosis and cardiogenic shock, if the gradient is low or high, as you can see here, if the gradient is low, the experts, the authors, propose that it is futile, maybe futile to perform TAVI. How long does the symptom last? The experience of the center that's going to do the procedure, and if there is possibility for transfemoral TAVI. All these are things that we have to consider when we think that when we balance utility versus futility. But what I would emphasize, and what in my opinion is more important, is time. As we know, and I will show this slide from Mayo Clinic that actually refers to all shock types. The deeper the shock stage, the worse is the outcome. And when the shock is very advanced, when the shock is at stage D or E, you can see that in-hospital mortality reaches 70%. That means that whatever we do, we have to do it early. I will close my presentation with some considerations, starting with technical considerations. First of all, what has changed actually, in my opinion, the TAVI procedure is the planning with a pre-TAVI CT. So we have to think if it is feasible, and we have to push to make it feasible to do a TAVI CT in these patients, even if they undergo an emergency procedure. There are alternatives. We can use 3D echocardiography to do the valve measurements. We can use ultrasound or classical angiography when we perform the coronary angiogram to see the peripheral vessels. Definitely, the femoral access is the way to go. Regarding valve choice, there are no data supporting one valve or the other, so each one should go with a valve which is more comfortable with. The management of the concomitant coronary artery disease, we have to be minimalistic. We have to do only the things that are absolutely necessary. Critical proximal disease in large vessels, like left main stem. And the use of interprocedural mechanical circulatory support is feasible. There are cases presented with ECMO or with Impella, but it has to be applied only if it is absolutely necessary. And this is my last slide before the conclusions, and I will set some considerations regarding TAVI cardiogenic shock in Greece. We have to think what is the reality in Greece and what we can achieve in our country. First of all, we have to think about the centralized way of valve reimbursement. We know how this happens. The reimbursement comes for a specific patient. Obviously, this is not possible for an urgent procedure, so maybe in these procedures, this approval, the centralized approval for reimbursement should happen retrospectively. More important is the long waiting time list in public hospitals. So there must be parallel pathways for the patients that they need an urgent procedure. There is the National Registry on TAVI Centers outcomes, and this registry should take into account the condition of cardiogenic shock, because obviously it's very different to do, as I showed earlier, to do a TAVI in a stable patient without cardiogenic shock. Mortality would be extremely low, but in a patient with cardiogenic shock, mortality would be high. And this should not affect the evaluation of the TAVI center. And finally, this decision should be very well balanced by a multidisciplinary team, a heart team, but I would say also a shock team, clinicians that they are familiar and they treat shock cases, because we have to balance very well between benefit and futility. Benefit for futility, not only for the patient benefit, but also for ethical reasons. I think there is an ethical dilemma in Greece when a lot of people wait for TAVI for months. To do a TAVI, an emergency TAVI in a futile patient, maybe is not the way to go. In conclusion, TAVI in cardiogenic shock is feasible and an effective option. We should expect, though, worse outcomes compared to patients with non-cardiogenic shock, and we should accept these outcomes. The most important thing is the careful patient selection, balancing benefit and futility. And I believe that balloon valvuloplasty remains a realistic interim solution, maybe as bridge to TAVI. Thank you very much.
Thank you very much, Ilias, for your concise and comprehensive lecture on a subject that we are not very used, especially in Greece, taking into account the problems that we've got, the way that TAVI can be approved, is approved, etc. So I would like, first of all, I would like to say good morning to Dr. Rubelakis, who is one of our commentators from, I hope, nearby, but not in the room. And I would ask Dr. Karabinos to make a few comments or questions to Ilias, and then we'll have one question from the audience and go on with the second presentation. Ilias, please.
Good morning, everybody. I'd like to thank Kostas and the organizing committee for this kind invitation. I come from Euroclinic, and it has just very recently started the program with TAVI after 5 years intermission. So we may have the opportunity to expand our experience in this field. Congratulations for this very thoughtful presentation. Just very few clarifications. You showed this TVT registry, which is really impressive. Over 15,000 patients from USA. It was with SAPIEN 3 valve.
Exactly. Yeah, only
it was not with core valve. The definition regarding the cardiogenic shock, which is a matter of interest, sometimes there is a confusion about definitions regarding, for example, inotropes, regarding blood pressure, which is not a mandatory prerequisite to define cardiogenic shock, since sometimes borderline pressures 9 to 10 or over 10 may coexist in cardiogenic shock. However, lactic acidosis is, there is always, and we have to look at that. Regarding BAV, I think it's okay. It's a solution when you don't have anything else to do. But the numbers are really very bad. 70% in some registries, the 1-year mortality. 3D echo, it may be a solution when this procedure has to be performed in an emergency condition. But we have to confess that we underestimate just 1 to 2 millimeters as compared to computed tomography. And we have seen that in a very recent meta-analysis regarding 3D echo in TAVI. So it may be just an alternative for the time being. So congratulations again. And I don't know, Chair.
Okay, thank you very much, Elias. Are there any questions from the audience that would like to be clarified? Dimitris, Professor Alexopoulos wants to ask something.
In the meantime, can I make a remark? Thank you for your excellent talk, to start with. You had 7% of patients in your center with cardiogenic shock. How did you treat those patients? Were you able to do things?
They all died. They died, all of them.
Okay. I thought so.
Yeah. That's why I'm talking
in a different direction in order to...
That's why I'm talking about BAV. Although BAV is very suboptimal, maybe it is a way to gain some time. To gain time.
We do it all the time, because you have to wait for a long period of time in order to get approval for your TAVI, and then your patients start to decompensate, and you have to do something about that, or else they die, as you said.
It's just a measure. It's just a measure to gain time, and maybe it gives you time, for example, to do the CT, which is necessary. Obviously, the 3D echo is not an alternative. It's only a suboptimal in emergency conditions. You do BAV if you cannot do emergency TAVI, and you give some time to the patients to organize all the other things. Just to make a comment, you are very right about the STS ACC registry. There are a lot of limitations. One of the limitations of the study is exactly what you mentioned. There are no data about hemodynamics. There are no data about metabolic issues like lactate acidosis. So this is a major limitation you have to take into account. So these patients that underwent TAVI in the registry, they were not in a critical condition, I would say. If you read carefully the manuscript, there were patients that they were maybe in cardiogenic shock, but not in a critical condition. Exactly.
Patients who were in inotropes had a better prognosis. Those who needed mechanical support were
Worse.
Professor Alexopoulos, and one more, please.
Congratulations, Grigoris. I apologize, I missed most of your talk, but I looked at your conclusions, and the first one regarding the problems in Greece with the approval for the reimbursements, it's not a problem, because in emergency cases like cardiogenic shock cases, we work on, let's say, hand by hand. We don't wait the 2 weeks process. It can take half of a day. So it's not a real problem. If there is an emergency case, we accept the applications and we approve it the same day.
Yeah, that's very reassuring.
Dr. Kilic wants to make a comment. Please do. We are very glad that you are here participating in this congress from Turkey.
Excellent presentation, thank you. I want to ask a question. Is there any comment about the balloon sizes used in the study? Because we know that in the past, when they used larger balloons, this means increased risk of development of aortic regurgitation at the index procedure. So is there any comment on the study?
I don't remember, to be honest, but I think that you make a very interesting comment that to use a smaller balloon for BAV still can have the effect that you expect and be safer. So I understand that this is your comment.
And also there are some important new development balloons, like V8 balloon, and this opened the valve different mechanism. So maybe in our countries, like the problems, especially in cardiogenic shock patients, these kind of balloons can be good alternatives. Thank you.
Thank you very much. Thanks, Ilias, and let's move to the next presentation, who is